Dialysis. Dialysis is where an artificial means is used to replace a kidney after kidney failure. The word dialysis comes from the Greek word dialusis, dia meaning through and lucis meaning loosen. Dialysis can be used for people who have become sick and have lost the use of their kidneys for just a short time, or for people who no longer have working kidneys. Clinically, dialysis is a technique in which substances move from the blood through a semi-permeable membrane and into a dialysis solution. An increasing number of individuals, including older adults and those with complex medical problems, are receiving maintenance dialysis. A patient's chronological age is not a factor in determining candidacy for dialysis. The general principles of dialysis are that solutes and water move across the semi-permeable membrane from the blood to the diacylate, or from the diacylate to the blood, in accordance with concentration gradients. In kidney failure, urea, creatinine, uric acid, and electrolytes such as potassium and phosphate move from the blood to the diacylate with the net effect of lowering their concentration in the blood. RBCs, WBCs, and plasma proteins are all too large to diffuse through the pores of the membrane. Small molecular weight substances can pass from the diacylate into the patient's blood, so the purity of the water used in dialysis is monitored and controlled. In peritoneal dialysis, excess fluid is removed by increasing the osmolarity of the diacylate via the osmotic gradient with the addition of glucose. In hemodialysis, the gradient is created by increasing pressure in the blood compartment, positive pressure, or decreasing pressure in the diastolic compartment, negative pressure. So, to rephrase for hemodialysis, extracellular fluid moves from the diacylate because of the pressure gradient. The excess fluid is removed by creating a pressure differential between the blood and the diacylate solution with a combination of positive pressure in the blood compartment or negative pressure in the diacylate compartment. In the United States, approximately 12% of patients receiving dialysis treatments are on peritoneal dialysis. Preparation of the patient for catheter insertion includes emptying the bladder and bowel, weighing the patient, and obtaining a signed consent form. The catheter is about 24 inches or 60 centimeters long and has one or two Dacron cuffs. The cuffs act as anchors and prevent the migration of microorganisms into the peritoneum. The tip of the catheter rests in the peritoneal cavity and has many perforation spaces along the distal end of the tubing, allowing fluid movement through the catheter. The technique of the catheter placement varies. It's usually placed surgically so that the catheter can be directly visualized, minimizing potential complications. After placement, peritoneal dialysis may be initiated immediately with low volume exchanges, or delayed for 2 weeks pending healing and sealing of the exit site. Daily catheter care varies. Some patients just wash with soap and water and go without a dressing, whereas others require daily dressing changes. Teach all patients to examine their catheter site for signs of infection. Showering is preferred to bathing. This is an image of what a peritoneal catheter exit site looks like. Dialysis solutions vary, and the choice of exchange volume is determined primarily by the size of the peritoneal cavity. A larger person may tolerate a 3-liter exchange volume without any difficulty, whereas an average-sized person usually tolerates a 2-liter exchange. Ultrafiltration, or fluid removal, during peritoneal dialysis depends on osmotic forces. Glucose is the most effective osmotic agent currently available. The 3 phases are called an exchange. For manual peritoneal dialysis, a period of about 30 to 50 minutes is required to complete an exchange. Inflow is the first phase of the exchange, and that's when the amount of the solution infuses into the peritoneal cavity. The amount is usually, like I said, about 2 liters. The flow rate may be decreased if the patient's having pain. Dwell is the next phase, and the duration of the dwell can be as brief as 20 to 30 minutes or up to 8 or more hours, depending on the method of peritoneal dialysis. Drain is the final phase, and it can last up to 30 minutes. After drain, the cycle starts again with the infusion of another 2 liters of solution. As previously stated, dialysis solutions vary, and the choice of the exchange volume is primarily determined by the size of the peritoneal cavity. Smaller exchanges used for patients with smaller bodies. But a couple other factors that might affect this are like Pulmonary compromise, where the addition of a large volume of fluid might precipitate respiratory distress, or the presence of an inguinal hernia might make a difference. In utilization of dextrose as the osmotic agent, it is relatively safe and inexpensive, but it's also associated with high rates of peritoneal glucose absorption, which lead to problems like hypertriglyceridemia, hyperglycemia, and long-term peritoneal membrane dysfunction. Automated peritoneal dialysis, or APD, is the most popular form of peritoneal dialysis because it allows patients to accomplish dialysis while they sleep. An automated device called a cycler is used to deliver the diacylate for APD. The size of the cycler is similar to a DVD player. The automated cycler times and controls the fill, dwell, and drain phases. The machine cycles 4 or more exchanges per night with 1 to 2 hours per exchange. It's difficult to achieve the required solute and fluid clearance solely with nighttime APD. 1 or 2 daytime manual exchanges also may be prescribed to ensure adequate dialysis. Another option is CAPD, or continuous ambulatory peritoneal dialysis. Using this method, exchanges are carried out manually with 2 to 3 liters of peritoneal diacylate 4 times daily, with dwell times averaging 4 hours. A common schedule includes exchanges at 7 a.m., 12 noon, 5 p.m., and 10 p.m. This slide is just a picture of the cycler and what it looks like in relation to the patient. Okay, so let's talk about some complications of peritoneal dialysis. Infection of the peritoneal catheter exit site is most commonly caused by Staphylococcus aureus or Staphylococcus epidermidis, which is normal skin flora. Clinical manifestations of an exit site infection include redness at the site, tenderness, and drainage. Most frequently, peritonitis occurs because of improper technique when connections for exchanges are contaminated. Peritonitis is usually caused by Staph aureus or, again, Staph epidermidis. The primary clinical manifestations of peritonitis are abdominal pain, rebound tenderness, and cloudy peritoneal effluent with a WBC count greater than 100 cells per unit, more than 50% neutrophils, or a demonstration of bacteria in the peritoneal affluent by Gram stain or culture. GI manifestations of peritonitis may include diarrhea, vomiting, abdominal distension, and hyperactive bowel sounds. Fever may or may not be present. Because of increased intra-abdominal pressure secondary to the diacylate volume, hernias can develop in predisposed individuals such as multiparous women and older men. Increased intra-abdominal pressure can cause or aggravate lower back pain. The lumbosacral curvature is increased by intraperitoneal infusion of diacylate. Bloody affluent over several days or the new appearance of blood in the affluent can indicate active intraperitoneal bleeding. If this occurs, check the blood pressure and the hematocrit. Atelectasis, pneumonia, and bronchitis may occur from repeated upward displacement of the diaphragm, resulting in decreased lung expansion. The amount of protein loss is usually about 0.5 grams per liter of diacylate drainage, but it can be as high as 10 to 20 grams per day. Unresolved peritonitis is associated with excessive protein loss that can result in malnutrition and may indicate the need to terminate peritoneal dialysis temporarily or sometimes permanently. Learning the self-management skills required to do peritoneal dialysis is usually accomplished in a 3 to 7 day training program. Mortality rates are about equal between in-center hemodialysis patients and peritoneal dialysis patients for the first few years. After about 2 years, mortality rates for patients receiving peritoneal dialysis increase, especially for the older patients with diabetes and with patients with prior history of cardiovascular disease. Now we're going to talk about hemodialysis, and we're going to start with the vascular access. A subcutaneous arteriovenous fistula, or an AVF, is usually created in the forearm or the upper arm with an anastomosis between the artery and the vein. Usually it's the cephalic and the basilic. In some situations, when immediate vascular access is required, percutaneous cannulation of the internal jugular or the femoral vein is performed. This slide is just a graphic of what the fistulas look like, with A, the top one being the arteriovenous fistula, and B, the bottom one being the arteriovenous graft. This picture shows what the actual fistula looks like created by anastomosing an artery and a vein. The fistula allows arterial blood to flow through the vein. The vein becomes arterialized, increasing in size and developing thicker walls. The arterial blood flow is essential to providing the rapid blood flow required for hemodialysis. As the fistula matures, it is more amenable to repeated venipunctures. Maturation may take 6 weeks to months. An AVS should be placed at least 3 months before the need to initiate hemodialysis. The fistula is the preferred access for hemodialysis. Normally a thrill, which is a buzzing sensation, can be felt by palpating the fistula. A bruit, which is a rushing sound, can be heard with a stethoscope. The thrill and bruit are created by arterial blood moving at a high velocity through the vein. These are images of those temporary double lumen vascular access catheters that are used in acute hemodialysis. Figure A is the soft, flexible double lumen tube that is attached to a Y hub. Figure B illustrates the distance between the arterial intake and the venous return lumina, which typically provide recirculation rates at about 5% or less. These are a couple other images of those temporary catheters. A is the right internal jugular placement for a tunneled cuffed semi-permanent catheter. B is a temporary hemodialysis catheter in place, and C is a long-term cuff hemodialysis catheter. Another option for dialysis is the hero graft. It consists of two pieces, a reinforced tube to bypass blockages in the vein, and a dialysis graft anastomosed to an artery to be accessed for hemodialysis. Here is the image. The hero graft is placed under the skin like both a fistula and a standard graft. The hero graft bypasses the venous system to provide blood flow directly from a target artery to the heart. Also, there are hemodialysis dialyzers. The blood is pumped into the top of the cartridge and is dispersed through all these fibers. Dialysis fluid, or diacylate, is pumped into the bottom of the cartridge and bathes the outside of the fibers. When the dialyzed blood reaches the end of thousands of semi-permeable fibers, it converges into a single tube that returns it to the patient. The hemodialysis procedure utilizes needles that are placed into the fistula or the graft. The needles used are large bore, usually 14 to 16 gauge, and are inserted into the fistula graft to obtain vascular access. When blood comes in contact with a foreign material, such as the dialyzer, it has a tendency to clot. Heparin is added to the blood to prevent clotting. In addition to the dialyzer, a diacylate delivery and monitoring system is used. Upon termination of the treatment, a saline solution is used to return the blood in the extracorporeal circuit back to the patient through the vascular access. The needles are removed from the patient and firm pressure is applied to the venipuncture site until the bleeding stops. Again, this is just an image that shows you the hemodialysis unit in relation to the patient. Before the procedure begins, the nurse needs to assess fluid status utilizing weight, blood pressure, peripheral edema, lung, and heart sounds. Also, the condition of the vascular access and the temperature. The difference between the last post-dialysis weight and the present pre-dialysis weight determines the infiltration or the amount of weight from fluid to be removed. Most people sleep, read, talk, or watch television during hemodialysis. The patient receiving long nocturnal hemodialysis has the advantage of sleeping while dialyzing. Each nocturnal treatment lasts 6 to 8 hours, and the patient dialyzes up to 6 times per week. In addition to in-center hemodialysis, home hemodialysis is available. The option for home hemodialysis often depends on the patient's family support. One of the main advantages of home hemodialysis is that it allows greater freedom in choosing dialysis times. In short daily hemodialysis, the patient dialyzes for 2.5 to 3 hours per session, 5 or 6 days per week. Short hemodialysis is usually done at home. Hemodialysis has its own set of complications. Hypotension that occurs during hemodialysis results primarily from rapid removal of vascular volume, or hypovolemia, which decreases cardiac output and decreases systemic vascular resistance. Factors associated with the development of muscle cramps include hypotension, hypovolemia, high ultrafiltration rate, which causes large interdialytic weight gain, and a low sodium dialysis solution. Blood loss may result from blood not being completely rinsed from the dialyzer, accidental separation of blood tubing, dialysis membrane rupture, or bleeding after the removal of the needles at the end of hemodialysis. At one time, hepatitis B had an unusually high prevalence in dialysis recipients, but the incidence today is low. Currently, though, hepatitis C virus is responsible for the majority of cases of hepatitis in dialysis recipients. Hemodialysis does not alter the accelerated rate of development of cardiovascular disease and the related high mortality rate. The yearly death rate among patients receiving maintenance dialysis remains high and is estimated to be between 19 to 24%. Individual adaptation to maintenance hemodialysis varies considerably. Initially, many patients feel positive about the dialysis because it makes them feel better and keeps them alive, but there is often great ambivalence about whether it's worthwhile. Moving on, let's talk about CRRT, or continuous renal replacement therapy. The principle of CRRT is to dialyze patients in a more physiologic way over 24 hours, just like the kidneys. CRRT is contraindicated if a patient has life-threatening manifestations of uremia, such as hyperkalemia or pericarditis, that require rapid treatment. Various types of CRRT are available. There's a table in your book, 46-14, that summarizes this, but the most commonly used are the veno-venous approaches of continuous veno-venous hemofiltration, or CVVH, continual veno-venous hemodialysis, which is CVVHD, and continuous veno-venous hemodiafiltration, which is CVVHDF. Vascular access for CRRT is achieved through the use of a double lumen catheter like those used in regular hemodialysis that's placed in the jugular or the femoral veins. This picture is a basic schematic of continuous veno-venous therapies. A blood pump propels blood through the circuit. A highly permeable, hollow fiber hemofilter removes plasma water and non-protein solutes, which are collectively termed ultrafiltrate. The ultrafiltrate rate, or the UFR, may range from 0 to 500 mL per hour. Under the influence of hydrostatic pressure and osmotic pressure, water and non-protein solutes pass out of the filter into the extracapillary space and drain through the ultrafilter port into a collection device, a drain bag. The remaining fluid continues through the filter and returns to the patient via the return port of the double lumen catheter. As ultrafiltrate drains from the hemofilter, fluid and electrolyte replacements can be infused through a port located before and after the filter as the blood returns to the patient. Replacement fluid is designed to replace volume and solutes such as sodium, chloride, bicarbonate, and glucose. Replacement fluid infused into the infusion port before the hemofilter allows for greater clearance of urea and can decrease filter clotting. The use of the infusion port located after the filter dilutes the intravascular fluid, decreasing the concentration of unwanted solutes such as BUN, creatinine, and potassium. Anticoags are needed to prevent blood clotting and may be infused as a bolus at the initiation of CRRT or through an infusion port before the hemofilter. As with hemodialysis, diffusion of solutes and infiltration via hemostatic pressure and osmosis occur. This is an ideal treatment for a patient who needs both fluid and solute control but cannot tolerate the rapid fluid shifts associated with hemodialysis. Those of you who get to go to the intensive care areas during your clinical experience will probably get an opportunity to see continual renal replacement therapy done. CRRT can continue as long as 30 to 40 days, but the hemofilter should be changed every 24 to 48 hours because of loss of filtration efficiency or potential for clotting. The ultrafiltration should be clear yellow. Specimens may be obtained for evaluation for serum chemistries. If the ultrafiltrate becomes bloody or blood-tinged, suspect a possible rupture in the filter membrane. Treatment must be terminated to prevent blood loss. It does not require constant monitoring by a specialized hemodialysis nurse, but does require a trained ICU nurse. It does not require complicated HD equipment, but a blood pump is needed for the veno-venous therapies. Although reductions in central venous pressure and pulmonary artery pressure are expected, there should be little change in the mean arterial pressure or the cardiac output. Assess and maintain the patency of the CRRT system. Once the patient's AKI is resolved or there is a decision to withdraw treatment, CRRT is discontinued and the needles are removed. So the last type of external dialysis machine I want to talk about is the WAK. The wearable artificial kidney, or the WAK, has recently been developed and is approved for use to improve the quality of life of the end-stage renal disease patient. The WAK is a miniaturized dialysis machine that can be worn on the body. The carrier resembles a tool belt. The device connects to a patient via a catheter. Like a conventional dialysis machine, it is designed to filter the blood of end-stage renal disease patients. Unlike current portable or stationary dialysis machines, it can run continuously on batteries and is not plugged in to an electrical outlet or attached to a water pipe. The present version weighs about 10 pounds, but future modifications can make it lighter and more streamlined.